is now available for anybody to watch. That reminded me, I need to record this lecture too. Anyhow, so this is what we're going to do, and hopefully you'll find it exciting and interesting. And if you do, maybe you should consider doing a fellowship in allergy and immunology. So a little bit of background about types of immunity, and we talk about it. When we educate patients about the importance of vaccines. So again, from last week, we talked about active immunity versus passive immunity. But then there's also herd immunity and community immunity. So herd immunity will only protect you from diseases that are transmissible person to person. So herd immunity is important for things like measles and pertussis, but there are other diseases that aren't transmitted from person to person. So while we emphasize the importance of herd immunity, don't get caught with someone then challenging you and saying, well, what about tetanus? Tetanus, you're not protected by herd immunity. So that's just more of a pearl for where somebody might try to get a gotcha if you're having a debate about vaccines. Again, we're going to go through the next couple of slides really quickly. Passive versus active immunity, transfer of immunoglobulin, that protection is temporary, versus actively stimulating your immune system and producing antigen-specific responses. And generally, active immunity will provide long-term and oftentimes permanent immune memory. Here is a new slide. So a little bit more detail about some forms of passive immunity for VPDs or vaccine preventable diseases. So you've got regular old IgG. Remember last week I said IgG is your longest living immunoglobulin. It lasts for about 3 to 4 weeks in the average human. In the newborn period, it actually can last 6 months and sometimes longer. So there are different formulations to get passive immunity with just generic pooled immunoglobulin type G. So you can administer it IV or you can receive it subcutaneously. You can also get a shot IM called gamma globulin, and that is just another form of pooled IgG. Then you have something called hyper-immunoglobulins, and that's where they take pooled immunoglobulin and they're able to select out specific IgG against a certain type of disease. So as you can imagine, this process is a bit intensive in terms of what the machines have to be able to do. And with that, it also becomes very costly. So generally, hyperimmunoglobulins, they're not cheap. However, if you find yourself needing to use it, it's most often going to be because you are in a clinical situation where this is potentially going to be life-saving. The more rare the antibody, the more expensive the hyperimmune globulin. So if you look across the US population, you will have people that were immunized against smallpox vaccine, either because of military service or because of age. But as the number of people in our population who donate blood grows to have fewer and fewer of those who have received smallpox vaccination, there's going to be a decline in the amount of hyperimmunoglobulin that's available that contains vaccinia, which is what you look for, not the actual smallpox, because we don't vaccinate with actual smallpox. An issue that was brought up, or not an issue, but a good note that was brought up last week has to do with something called Synagis or palivizumab. So it is a monoclonal antibody that is used to prevent RSV, respiratory syncytial virus, in at-risk infants. So many times people think of it as a vaccine, but it is actually a hyperimmunoglobulin or a monoclonal antibody, and it is used to passively protect during those windows of exposure or RSV season. Again, we're gonna go through this fast. B cells, humoral immunity. They make antibodies. B cells kill what's only extracellular. T cells, think cell-mediated immunity, so more targeted, your sniper. Two main types that we talk about: killer T cells kill, helper T cells help, and they specifically are going to help boost the B cell response, but they can kill only intracellular bugs, and they can only see antigen that is presented on the MHC. B cell activation, so Batman and Robin. If you didn't watch the Immunology 101 lecture, this will make some sense, but the reference is going to be very confusing. So B cell is Batman, T cell is Robin, and it's specifically the helper T cell that's going to help. So you can have T cell dependent, which is Batman plus Robin, and that is reacting to proteins or peptides, because that's what the MHC presents. But strong immune response, isotype switching, most of your memory B cells come from this type of activation. Then you've got Batman only or T cell independent. So that's how you respond to polysaccharides, lipids, nucleic acid. Not a lot of isotype switching. It's mostly IgM, and you can make some memory B response, but overall this response is not very strong, and it's very poor in children under the age of 2. Also from last week, in a term infant, their IgG matches maternal IgG because maternal IgG is the only thing that crosses the placenta. IgA, IgM, IgE does not cross the placenta. The majority, but not all, is going to be gone at 6 months. So the timing of infant vaccines really is to help provide as much protection by that 6-month mark as you can, because that's when maternal passive antibodies really dip. B cells not completely functional until after birth. Children under 2 have impaired production to antibody types, specifically polysaccharides, and more specifically encapsulated bacteria. Also, people without spleens, whether they are functionally asplenic, like your sickle cell patients, who essentially have microinfarctions and they become functionally asplenic, or someone who's had to have their spleen removed surgically, either because of trauma or disease, they can have similar issues with encapsulated bacteria. Conjugating a polysaccharide with a protein is the workaround, because when you put a protein there, now T cells can see it. So you get helper T response, you get Batman plus Robin. So encapsulated bacteria, so oftentimes I will call these your candy-coated pathogens, because they have this hard polysaccharide outer encapsulation. So I like to think of them as like dangerous M&Ms. But if you have only Batman, you're going to have a hard time in the very young or the asplenic conquering some of these bacteria. So again, anybody who's done board examinations recently or been prepping for board exams, these are important questions. And at the bottom, so Salmonella typhi is an encapsulated bacteria. So I can recall the vignette that was very classic when I was prepping for the pediatric boards is what type of bacteria is kind of be pathognomonic with patients who have sickle cell disease. And at least 15 years ago, it was Salmonella typhi, osteomyelitis. And the reason why they become vulnerable to encapsulated bacteria is because of that microinfarction of their spleen. But also, group B strep is an encapsulated bacteria. Anybody who works in OBGYN will recognize the importance of treating GBS positive mothers for a certain number of hours prior to delivering the baby. And then things like, pneumococcal pneumonia, Hib meningitis, meningococcal meningitis in very young, we have been able to decrease that. So when I was in training as a resident back then, my staff had all seen Hib meningitis, meningococcal meningitis. They had seen the devastation of these bacteria when they were training and when they were young pediatricians. In my entire career, I've seen meningococcemia one time, and I've never seen someone with Hib meningitis. And so if generationally we look back at who taught us, those of you currently in training, the people training you, they may have never seen any of these diseases. And again, that speaks volumes to the success of vaccines. So we're going to get into some vaccine overview. What is a vaccine? And keep in mind, you know, my clinical history includes doing vaccine adverse event evaluations. So I look at vaccines very methodically. I'm a huge supporter of vaccines, but I also know that vaccines are still a medication, and no medication is 100% safe. None. I mean, you can have side effects from Tylenol. You can have issues with just taking a baby aspirin. So a vaccine is a medication. That being said, it is largely very safe and very effective administering vaccinations. So a vaccine is a biologic preparation to improve immunity against a particular disease. And we are trying to stimulate active immunity. So hyper-immunoglobulins are not vaccines. They don't stimulate the immune system to produce its own immune memory. Now, vaccines can be truly prophylactic, meaning you receive the vaccine to ever prevent the disease, and it's given before any known disease exposure. So we give people tetanus vaccines when they're infants, not because we are potentially concerned that they have been exposed to tetanus, or giving children chickenpox or a varicella vaccine. We give it to them before they've ever had a known exposure. But vaccines can also be used therapeutically, and I view therapeutic vaccine use as part of post-exposure treatment. So while usually it's called PEP, post-exposure prophylaxis, I think of it still as part of a package of therapy because there was a high-risk exposure of some sort. So let's take rabies. So if you've had a high-risk animal bite or a bat exposure, you are going to receive post-exposure prophylaxis. That includes hyper-immunoglobulin plus the vaccine. And hyper-immunoglobulin will provide some protection in the immediate time frame, and it allows your body some time to actually make its own antibodies against the rabies virus, because rabies can linger in the human body for a very long time, and there's no cure for rabies. So in my mind, if I as a clinician have decided that a patient meets the criteria for a high-risk animal exposure, and I'm going to initiate post-exposure treatment with a vaccine, you absolutely must also give the hyper-immunoglobulin, because that is a package deal. So a little more getting into what are vaccines, what are vaccine types. So two main categories are live and killed. Your live and attenuated vaccines basically are the infectious agent is processed over and over again to attenuate or decrease how virulent it is. You try to disable it, but it is still living, and that is important in order for there to be vaccine response. You have to have some micro replication happen, but you don't want the person to actually get the full-blown disease. Inactivated or killed vaccines can be further broken down into toxoid vaccines, subunit, and conjugate vaccines. But inactive vaccines or killed vaccines are just that, they are killed. So when people say, every time I get the flu shot, I get the flu, well, the flu shot is an inactivated vaccine. It is actually physiologically impossible to get the flu from the flu shot. You can't get rabies from the rabies vaccine. All of these are inactive. Toxoid vaccines primarily are tetanus and diphtheria. So we make the vaccine, like I make it. The vaccine is made using the actual toxic component, not the bacteria that produces it. Then you've got subunit vaccines, and they take the part of the organism or the pathogen that is the most highly antigenic and the most important one to have antibodies against. So hepatitis B is a subunit vaccine. They don't just take the virus, kill it, and then put it in a milieu and shoot it into a syringe. They only take fragments of it. And then, as I mentioned before, and I'll talk about again, conjugate vaccines. So you take the polysaccharide coating of a bacteria and you pair it with a protein. So Hib, or Haemophilus influenza type B, is a type of conjugate vaccine. A little bit more, and anybody who has had to be the person in charge of a clinic, or you've been tapped to cover the vaccines within your clinic setting, or even within, you know, your larger hospital, will know that some of the issues that surround vaccines is how they are stored and what can damage it. So I'm going to go into a little bit of detail there, and hopefully it'll make more sense why this is such a hot topic. So again, live attenuated pathogens, they're weakened and they're going to mimic kind of a mini disease. So it has to retain the ability to replicate. Usually, this won't cause fulminant disease, but there is potential for severe reactions due to the replication. And there's also potential for mutation in some cases. So then that mutant attenuated pathogen actually becomes a little more powerful. It's potential, but most of our live vaccines have actually been around for a very long time. And with that, the most of the issue or most of the clinical problems that surround them are related to either them triggering just a robust immune response, or the potential for replication beyond just the injection site. Now, the good thing about live vaccines is they're very powerful. So when you inject a live vaccine, or when you take an oral live vaccine like polio, you can oftentimes get effect with just one dose. But the problem is that you have a live organism. So that live organism in the vial can be easily damaged, and it can be damaged by heat, by light. It can be damaged or inactivated by antibody containing products. It can also have less efficacy if the patient is taking antivirals or some antibiotics, which makes sense, because if you're on an antiviral and it's a viral vaccine that has to replicate, potentially that antiviral might interfere with replication. So it's always important, if a patient's going to have a live vaccine, to be aware of any antiviral medications that they may be on. Now, there are plenty of antivirals that will not interfere with vaccine replication, but then there are other situations where you want to take a pause and you actually want to double check. I also want to add that in this day and age of so many immunobiologics, you've got so many drugs that are wonderful at targeting to turn off a particular part of the immune system for things like rheumatoid arthritis and lupus and ulcerative colitis and Crohn's disease and psoriasis. However, they are turning off part of the immune system. And therefore, anytime a patient is started on one of these medications, you should always verify whether or not there is going to be any risk with the receipt of live vaccines. Sometimes they cannot receive live vaccines while on the drug, but within a few weeks of stopping it, they can receive those vaccines. In other instances, you may want to vaccinate the patient before starting the drug, because you know that they're going to be on it for long term. And then in the instance of a drug like omalizumab or Xolair, there's no significant immune suppression. It's only targeting your IgE, which is not really important in fighting pathogens. So someone who's on omalizumab, that's not a contraindication to getting live vaccines. All right, so I'm going to pivot to the right side of the screen, which is inactivated pathogens. So they are inactivated with heat, chemicals, radiation, but again, they cannot cause disease, and they stimulate a weaker response than live vaccines. So live vaccines carry risk. They're very delicate. It's like handling, you know, this like frail little snowflake, so to speak, but it is very powerful. Inactivated pathogens, They're a little more durable in terms of cold chain management and transportation, but the immune response is not as strong. They may require something called an adjuvant and or multiple doses to boost. And I'll talk more about adjuvants later and what they are. But the good thing about inactivated pathogens is that it's inactivated. So it's safe for someone who's immunocompromised, and they're more stable than live vaccines. Now, one thing to keep in mind though is if someone is being immune suppressed, sometimes they will have poor vaccine response. And that's what the warning is in some of these package inserts. It's that you're not going to respond to the vaccine, but an inactive vaccine will not cause disease. So I don't want people to confuse vaccine danger with just poor response in immunocompromised. Again, that is with inactive vaccines and some immunocompromised or immunosuppressed. So we're going to talk a clinical example that hopefully will make sense and tie the first couple of slides together. All right, so there's two types of pneumococcal vaccines that exist. You've got Pneumovax and Prevnar. Pneumovax is a polysaccharide vaccine, and generally people think of Pneumovax as something for senior citizens because that's how it's advertised. And then people usually think of Prevnar as something for children because for most of the time that Prevnar has existed, it was a pediatric vaccine. Now, Pneumovax has 23 different serotypes, while Prevnar has 13. Pneumovax, because it's a polysaccharide, will elicit a poor response in anyone 2 and under. So if you look at the package insert, it can't be given under 2, not because it's dangerous, but because it won't work. It uses B stimulation independent of T cells. So polysaccharide Pneumovax triggers Batman without Robin. So less robust, less powerful immune response. You don't get T cell memory, but you have B cell memory, and the T cells can't see the polysaccharide anyway. Now, Prevnar, on the other hand, is a conjugate vaccine. So it's Batman plus Robin. That's why it works in children. And because you're using B cell and T cells, you get a strong immune response and you get much more powerful immune memory. So when people talk about pneumonia vaccines, these two vaccines are not interchangeable. They are very different for different reasons. Pneumovax has a broad number of serotypes. Prevnar has a narrow number of serotypes, but a more robust immune response. So nowadays, and probably for the last about 5 years, you have anybody who watches commercials may have noticed that Prevnar is marketed now towards senior citizens and adults who might have chronic issues like lung disease. Well, the scheduling of these two vaccines is also generally important to get the most bang for your buck. If a patient is pneumococcal vaccine naive, you give Prevnar first because you're going to engage Batman plus Robin, and some of the serotypes in Prevnar are also contained in Pneumovax. So when the body sees Pneumovax at a later time, you are actually triggering a boost to some of the serotypes that there's already immune memory to. If you give Pneumovax first, it's okay, but it's not ideal because you're not going to be boosting an element of T cell memory when you later give Prevnar. You are actually doing initial T cell triggering if you give Prevnar later. This is also why you have an ideal window of no less than 8 weeks between the two. A lot of times, for just the ease of recall, they say a year. Give one this year and then give the other a year later. But realistically speaking, you can have 8 weeks between the two doses to allow for the first vaccine given to have enough time in the body to trigger some immune memory. And then you give the second vaccine. If you give both at the same time, you lose the whole point of administering both. They're supposed to boost one another, but they're not a vaccine series. They are two different vaccines targeting overlapping serotypes using different mechanisms of the immune system. So hopefully any of you that vaccinate, and actually if you vaccinate children who are at risk, you may also be giving them Pneumovax once they hit 2, but they've already had Prevnar, and so you're not so concerned about timing. But if you take care of patients with significant lung disease, or children who have asplenia, or children with sickle cell disease, you should be administering, or their hematologist should be administering Pneumovax when they turn 2. But this is the reason why you wait till they're 2. But those of you who take care of adults, this is an important distinction just to be able to understand so that you can communicate it to the patient. Also, if you send a patient to the immunizations clinic and you write a prescription and it just says pneumonia vaccine, you're wrong, because you need to be specific. Now, I know at Tripler and when I was at Walter Reed, we would figure it out. We would go in the patient's record, look and see what they had, when they had it, and then we would do the discussion with the patient. But realistically, the person who's writing the prescription, you should write for which vaccine is indicated, because you should know. That would be like writing a prescription for antibiotics and then sending them to the pharmacy and hoping the pharmacist will figure it out. Administration. So this is more about timing, but it's timing as it pertains to live vaccines. So a lot of times people are like, oh, you can't give any vaccine 4 weeks after you've given another vaccine, but then how come you can give so many vaccines on one day? And isn't there something that is involved with your PPD? Okay, so I'm gonna break it down as simply as I can. As a general rule, live, injectable, or nasally administered vaccines should be either given together or separated by 28 days or 4 weeks. Now, currently, there is not widespread use of intranasal flu, but intranasal flu is a live vaccine. So I include it here should it ever kind of come back and be more widely used. But injectable vaccines, live ones, either give them on the same day or you got to separate them by 4 weeks. And I'll explain that on the next couple slides. There's no evidence at all that live oral vaccines have any effect on other vaccines or other orally administered vaccines or injectable vaccines. So bottom line, when it comes to live oral vaccines, you can give them anytime, any spacing, don't worry about it. Women should avoid becoming pregnant within 28 days of receiving a live viral vaccine. The theoretical risk is that it's a live vaccine, so there's going to be vaccine replication, and the concern is that there may be some viremia that happens from that live vaccine that could potentially pose a risk to the developing fetus. But it's all theoretical. Have there been females who received a varicella vaccine or a smallpox vaccine and then within a month became pregnant or found out they were pregnant? Yes. And there have been registries that have followed these clinical cases, and there hasn't been any documented impact on the developing fetus that is unusual or triggers any concern. So it's a theoretical risk, but this is where it's rooted. So why the spacing? Anybody who listened to last week's lecture knows I like cartoons. I'm a visual person, but it's animated in my head. So the body has pro-inflammatory and anti-inflammatory chemicals called chemokines. So your pro-inflammatory chemicals will tell your inflammatory cells, hey, here's where the action is. Come over here, come over here, come over here. We all need to get fired up and start releasing our more chemicals and drawing more cells here, and that's what causes inflammation. Well, you also have chemicals that come around and tell everybody it's time to settle down. You've had enough time here. You've caused enough damage. Now anti-inflammatory comes in, and it's kind of like taking a bucket and pouring it on a fire, because you want everything to go back to your status quo, your even Steven. You don't want to have uncontrolled inflammation. It's damaging. And anybody who's really fascinated by a lot of autoimmune or autoinflammatory diseases, or even some of the current scientific discussion about COVID-19 and how the damage is all rooted in uncontrolled inflammatory responses. You'll find this really fascinating because you're going to be like, well, where are the anti-inflammatory chemokines? Where's your body's natural ability to turn these things off? Which is a whole other issue, which we're not going to get into, but just trying to make it timely. Anyhow, so if you can imagine, you had a campfire, then you poured a bucket of water on the campfire. You need to let that campfire wood dry out, because if you try to light it, if you light a match, it's not going to burn. Well, now we're going to talk live vaccines. So the live vaccine, the first one, is the original campfire. It triggers an inflammatory response. Then the body pours water on it, but there needs to be time for all of the anti-inflammatory chemicals to go away before you can give vaccine number 2. If you give vaccine number 2 too early, it's like putting a match on wet logs. You get no response. And that's why we have the spacing that we have. So if you give a second live vaccine too soon, you don't count the second vaccine, you only count the first vaccine, and then you have to wait several more weeks before you can re-administer the second vaccine. But that's the reason why. So if you think about it, and the fact that it's a fire and a campfire and wet logs, and live vaccines need to replicate in order to work, well, now it makes sense why this spacing only pertains to live vaccines. Inactive vaccines don't have to replicate, but they still trigger inflammatory responses, but it's not the same. Live vaccines, they need to replicate, they need to do their thing, and the anti-inflammatory chemicals will interfere with that replication. So it doesn't work. And hopefully a couple of people are having like the, oh, now I get it, totally makes sense moment. So along similar lines, vaccines and passive immunoglobulins can also have interference. So when you look at spacing of live vaccines and antibody-containing products, this is the reason why. So the antibody-containing products, it can be hyper-immunoglobulin, it can be IVIG, it can be a whole blood transfusion, but anybody who's received blood product that could contain antibody will oftentimes have that screening question on your vaccine intake form. And the reason why is you can't receive certain live vaccines within set amounts of time. And the amounts of time vary. So it's not universal that if you've had a blood product, everybody's got to wait 4 weeks before you can get a live vaccine. There are lengths of time depending on what product you received and what kind of vaccine you want to be given. But that's the reason why that passive antibody will inactivate the live vaccine before it ever has the opportunity to replicate and stimulate an immune response. If the live virus is given first, ideally you want to wait 14 days before administering an antibody-containing product. Obviously, in some situations, you don't really have, the luxury of time. So if necessary, to administer an antibody-containing product, less than 14 days after receipt of a live vaccine, give the antibody-containing product if that's the more important thing, but then consider revaccinating after that antibody has degraded. So hopefully that makes sense. So the clinical example, and something that I mentioned last week, has to do with measles-containing vaccine and maternal antibodies. So again, most passively transferred maternal antibodies are gone by 6 months, most, but not all. And measles vaccine, the measles component in MMR is exquisitely sensitive to antibody deactivation. And there can be maternal antibodies against measles that survive up to 12 months. And so if you administer measles vaccine at 11 months of age, a month early, you have to discount that dose. Now, if there's a measles outbreak, you give the vaccine early, but you just don't count it. But if you have a patient who just wants it given out of convenience, there's different there's different windows of what will be accepted before the first birthday. The CDC recognized a 4-day wiggle room. So if it's given 4 days before the first birthday, the CDC will count it. But individual school districts may only have a 2-day window. But they shouldn't have a window that's longer than the CDC's window. So if it's given a week early, that should not be counted. And you kind of do your patients a disservice. You think you're helping them out. Oh yeah, let's just give it a week early because I don't want to make you come back just for shots. It's actually better to give it a week late because the schools will not accept that one that was given a week early. And if the parent comes and asks you, hey, Dr. So-and-so, can you write me a note that excuses my child? Your answer should be no, because you are bound by what the CDC guidelines are. And now you understand the reason why. Vaccine screening questions will include questions about receipt of blood products. You can either go to the CDC or the Red Book. So if you do pediatrics, the Red Book is a great resource for pediatric infectious disease and vaccines. And it will talk about the vaccine specific wait periods and how long for what product was received. In some clinical settings, you're going to give post-exposure prophylaxis, like I talked about. So rabies, you give a hyper-immunoglobulin plus a vaccine. And that's because you're going to do passive immunization first, and then you're going to vaccinate because you also want the body to develop its own immune memory and make its own antibodies to whatever the agent is. So TB skin testing and vaccines. So remember the campfire? So same kind of thought process applies here. If you're going to do a PPD or a tuberculin skin test and you're going to give live vaccines, you either give them on the same day or give the PPD first. And then after you've read it in 72 hours, then you can give the live vaccine. If you do the reverse, if you give a live vaccine first, now you have to wait 28 days before you can place a PPD. But once a PPD is read, the PPD is not super strong, so it's not going to interfere with the live vaccine, but the live vaccine is strong and that will interfere with the PPD reading. So similar to two live vaccine injections, either give them on the same time, or if the live vaccine is given first, you got to wait 28 days. So that's why, sometimes people are like, oh, can I come back and do something later? Well, because they have to come back in within 48 to 72 hours to get a PPD read, then give the PPD first, because the patient is obligated to return for the reading on the same day as you read, then you give the live vaccine. So what's in a vaccine? A lot of times, vaccines get blamed for a lot of things, and I'm not going to go deep into the woods about all the different things that people think vaccines cause versus some of the adverse events that are tied to certain vaccines, but we're going to talk basics of what's in a vaccine. So two main components. You've got the antigen, which is either protein and or carbohydrate, but you got the antigen. That's what gives you specificity. That's what tells you make antibodies against hepatitis B. Then you've got your formulation and delivery components. So these are all the other things in the mix. And that's what will impact things like the timing of the vaccines, the timing of multiple doses, the magnitude and how much you have to administer, the route of administration, the quality of the reaction, the location you can give it in, whether or not something can be given subcutaneously versus intramuscularly versus orally. So a lot of the things that determine everything about vaccines is actually in the formulation and delivery. Now, ironically, a lot of the things that anti-vaccination folks point to also has to do with these formulation and delivery components, because the antigen itself is going to be the same antigen that's in the live vaccine or bacteria. So that part exists in nature. And so if you actually get the chickenpox vaccine, you're being exposed to the same antigenic things in a vaccine versus the actual disease versus the formulation and delivery stuff, which is important. So a little bit more details. I'd already mentioned adjuvants. And what's an adjuvant? So an adjuvant helps stimulate the immune system's response to whatever it is that it's given with. A key example of an adjuvant is aluminum salt or alum. So if you think about it, all right, so we've talked about live vaccines. Live vaccines are really powerful. So live vaccines don't really require an adjuvant, but inactive vaccines or killed vaccines, they're not as strong. So sometimes they need an adjuvant with them. And that adjuvant literally is like the extrovert that's the +1 with the introvert who's actually invited to the party. So the introvert is the one who got the invite. The extrovert is the one that draws all the attention to itself. That's the adjuvant. Then you have your suspending fluid, which is literally can have mixtures and trace amounts of some of the chemicals that are used during production of the vaccine to kill or weaken the vaccine itself. Then you've got your preservatives and stabilizers. That's what ensures that the potency remains unchanged. So if you have a multi-dose vial, it must contain a preservative. Single-dose vials don't have that preservative, but they still have to have stabilizers in them because you don't want time to degrade any sort of potency, but it just doesn't have a preservative in it. Single-dose vaccination manufacturing is more expensive than multi-dose vials. However, because of so much concern raised, specifically about thimerosal, and thimerosal is a preservative, in the US, all of our pediatric vaccinations are single dose. Unfortunately, because the manufacturers went to single dose and moved away from multi-dose, a lot of folks who are anti-vaccine took that as admission of guilt that, aha, see, if thimerosal were safe, you wouldn't have gone to single dose vaccine. A lot of times, if you think about, public pressure and concerns being raised, sometimes your intent to make things just the safest and decrease people's concern actually raises people who sit in conspiracy corners and think that it's actually an admission of guilt. But anyhow, I digress. Then you've got your residual materials. So some vaccines are grown in eggs. Some have antibiotic trace materials because of the processing to grow and inactivate the virus or bacteria. And all of those residual materials can still make their way into the end product or the vaccine. So I'm an allergist, so I still have to think about allergies and allergic reactions. The majority of vaccine reactions that are true reactions or attributed reactions or even not true reactions are not allergic. So generally, the things that an allergist can actually test and evaluate for are reactions that fall along the spectrum of an IgE-mediated or anaphylactic reaction to a vaccine. That's what we can skin test for. We can skin test for some of the components, not just the vaccine itself. But if somebody says that every time they got their flu shot, they got headaches and muscle aches, that's an inflammatory reaction. It's not specific. And it's not an allergic reaction. I always find it funny, and kind of like funny meaning like what doctors find funny, when people ask, is it gonna hurt before they get a vaccine? Because I'm like, yeah, it's gonna hurt. I'm injecting you with a needle through your skin. So yeah, it's gonna hurt. Is it gonna hurt like pushing out a baby? No, it's not gonna hurt that much, but it's a needle going in your arm, so it's not gonna feel like fun. But anyhow, yeah, no, some people are like, well, every time I get a shot, my arm hurts. I always find that an interesting complaint. And anybody who's ever had to run the flu drive at their clinic has probably seen a lot of these. So below are the ACIP vaccines and what the allergenic components are that are in it. In red, though, want to draw attention because I still see this happen. Flu, having an egg allergy is no longer an issue or a reason to not give someone a flu shot. Don't worry about it. Ignore it. Ignore it. You don't care about egg allergy when you give a tetanus vaccine. You don't care about egg allergy when you give HPV vaccine. Stop caring about egg allergy when you give a flu shot. The same thing, this was actually urban myth that MMR vaccine and egg allergy had some sort of issue. As you can see, there isn't even trace egg protein in the MMR vaccine, but for some reason, every once in a while, I have actually come across patients who are like 15 or 14 years old. So they were born in the 2000s when we absolutely had squashed MMR and egg allergy. That's urban myth. And yet the parent says, well, because the kid had an egg allergy, they never got their MMR vaccine. No, please stop doing that. But as you can see on the list, there's a lot of allergenic things that can be contained within a vaccine. And so this is why we ask about these types of allergies. Also, if someone has a history of systemic latex reaction, so the anaphylaxis from latex exposure, you want to verify within the package insert whether or not the stopper has latex. So thimerosal and formaldehyde, they're not known to cause anaphylaxis, but they can cause a delayed type hypersensitivity reaction when it's directly in contact with the surface of the skin. But if someone says I have a thimerosal allergy, they'd be hard pressed to try to say, yeah, sure, I had an anaphylactic reaction. They might have a contact reaction. That's not a contraindication though to vaccinating them if the vaccine has thimerosal in it. So a little bit about flu, because flu tends to confuse folks and it's given every year. So this is from 2017. So some of the stuff on here, like flu mist, I really don't count flu mist anymore. But as you can see, different vaccine types, even for flu, have different potential trace allergenic things in them. So if someone says, I'm allergic to the flu vaccine, and they actually had a true IgE-mediated anaphylactic reaction to the flu vaccine, important things, if you're gonna send them to an allergist, and I recommend you do send them to an allergist, is to write down for the patient what it was that they had in terms of vaccination. So if you just look at CDC guidance, an allergic reaction to the flu shot is a contraindication to the receipt of future flu shots. Well, I have actually had patients who did have anaphylaxis to the flu vaccine. Not a lot, it's probably half a dozen. And all of them were people who wanted to receive further flu shots and successfully received further flu shots. So the important thing is knowing what they got, because let's say someone had flu zone vaccine. Well, because of gelatin, you not only are worried about future flu zone, but also you're more concerned about that allergenic component being gelatin. And is it possible that this person might have an anaphylactic reaction with some of their future gelatin containing vaccines? And then highlighted are some of the ones that you would be concerned about. You know, you've got bovine versus porcine gelatin, and there's a question whether or not there's cross-reactivity there. But this is really just to highlight the fact that not all vaccines, even for flu, are going to be identical. And more often than not, if someone has anaphylaxis to a vaccine that has multiple different manufacturers, different formulations of that same vaccine will have different components, and they can more likely than not receive a different kind of that vaccine. So what if somebody received Afluria or fluvirin? Well, now you see other components like the neomycin component and where else it might be found. So it's not just enough to say, oh, you anaphylaxed to the flu vaccine, no more flu vaccines for you ever, whether they're children or adults. And I highly recommend that you send them to an allergist, but you do the biggest favor to the allergist by writing out what the vaccine was. You can even just send them with the package insert or something that the allergist can then receive and know exactly what type of vaccine was administered. This is how vast the list is of different vaccines and different manufacturers, but let the allergist be the detective. Let us figure out, because that's why we have longer appointment times. We'll figure out what we have, what we need to get, and what we need to test for. So some clinical pearls to round it out. Childhood immunization schedules are meant to provide protection during windows of vulnerability. Live vaccines are delicate snowflakes, and they can be troublemakers. So where can they cause trouble? With things like cold chain management. Vaccine-related issues that are true adverse issues. So not, I think my type 1 diabetes was caused by my vaccines and there's no true cause and effect, but someone who truly does have an issue with a vaccine, more often than not, that issue is going to be caused by live vaccines. So someone receives a live vaccine and then they find out that they're pregnant. Someone gets a live vaccine and then, oh, by the way, I forgot to mention, I'm currently undergoing chemotherapy and I'm immune suppressed. So those are the ones that kind of tend to cause trouble. Vaccines are medications. Side effects can occur. A side effect is not the same as an allergy to a vaccine. And as clinicians, it's important that we distinguish between the two. So if the patient says, I can't get the flu shot, I'm allergic to it, you need to ask, what do you mean you're allergic to it? I don't see it in the record that you've ever had anaphylaxis. Oh, well, every time I get the flu shot, I get the flu. That's not the same. That would be like someone telling you, well, every time I take an antibiotic, I get a little bit of diarrhea. You would not consider that an allergy to the antibiotic. You would consider that a side effect. If you have a concern for a true allergic reaction, or if the patient reports significant inflammatory reactions, so every time they get vaccines, they get myalgias and fevers, and they're just in bed with a flu-like illness, you can refer them to an allergist, and some discussion can occur with things like pre-medication before the vaccine, or potentially modifications of the dose. Again, I'm not going to go into off-label use, but those are things that an allergist would have the knowledge to be able to advise and make some decisions. And usually you can get to a point where that patient is still able to receive vaccines. So don't go and exempt someone from all vaccines just because of one adverse issue. Please refer them to an allergist, and they'll be able to figure out kind of the what next. And I think, okay, so some good information websites. I'm a huge fan of the Pink Book. The CDC's Pink Book, I've read it. It's really interesting because it outlines a little bit of the history of disease, but it's like super short chapters. So if you're like, you know what, I don't really know that much about diphtheria. I sure want to learn about diphtheria, but I don't have a lot of time because, you know, I'm so busy in my social isolation. Go onto the CDC's Pink Book and look up diphtheria, and you'll get a little bit of history. It's kind of like a tasting menu of facts. And if you're a nerd like me, who doesn't appreciate, you know, getting your learn on, especially when there's not much else you can do because you have to stay at home on the weekends. And I think that's it. So I will now open it up for questions. You can either unmute or you can put it in the chat box. Or nobody has any questions and everybody feels really, really smart now about vaccines and you're just ready to go and counsel people. Nobody has any questions? That's amazing. Okay.
Can I ask you a question?
Absolutely, ask away.
All right. I just like listening to you riff and speak, and I feel like I didn't get it. You got a little taste of it, but maybe just a bit more of your like approach to, you know, a vaccine skeptical parent, and just kind of, obviously everyone's different. They have their own reasons and what they heard, but kind of some of your generic kind of ways you go about that. Because I feel like often, quote, the facts are not really the problem, you know? And you know, someone gets me to explain it and then they just feel so great. So anyways, curious what you had to say about that.
Oh, so that, I mean, that's a great question. You know, one of the things that I probably have over you is a lot of years of hearing all the different kinds of reasons why. So point number one is you've got your vaccine hesitant parent, and when you're able to word things confidently and you're able to acknowledge what they're concerned about, usually they will buy in. So for example, a common question or concern may be, I'm just so worried about the baby getting so many shots at once. It's so many vaccines at once. So important things to educate them on is, hey, I understand. And that's actually why there's so many combination vaccines, to limit in infants and young children how many actual injections that they get. But the vaccines themselves contain the kind of high value components of the bacteria, meaning these are the parts of the bacteria that will stimulate an immune response. If you actually got the infection, that has a whole lot more stuff that will trigger the immune system. So you can talk about kind of the ratio of what you get exposed to by vaccination versus what you might get exposed to if your child actually got the native disease. Another thing you can talk about is, you can talk about the kind of the limitations of herd immunity and the limitations of maternal passive immunity, and letting them know that right now, the first 6 months of your baby's life is Mother Nature giving us time to get your baby to catch up by giving them vaccines. So when you take a vaccine schedule and you take 2 years to get done what you should be able to do in 6 months, you actually will open your child up to windows of vulnerability to certain diseases. And the problem is that because we don't see these diseases very often in our communities, because most communities are very vaccinated, parents don't understand how severe these diseases can actually be. And you know, I would, you know, people talk about how COVID is like, you want to see a world without vaccines? Well, this is what it looks like. I think that can be a little bit extreme, but you know, the reality of how devastating infections like measles and chickenpox can be, or Haemophilus influenza type B, can cause devastating meningitis to the point where you've got permanent cognitive issues in children if they survive. That's the reason why these vaccines are created. Sometimes you can just convince them by talking basic science. It's like, hey, I get it. You're worried. Is this too much for your baby? This is your perfect, you know, little person, and you don't want to do harm. And really, at the end of the day, the pediatric vaccine schedule, the goal is to protect the baby to the best that they can be protected, and understanding that as a parent and as a healthcare provider, you actually have the same goal. Your goal is to have this tiny person grow up to be a healthy human adult, and so you're on the same page. That would kind of, that's kind of generic. Now you may have some patients that are like, well, but I was always told that, you know, if you're egg allergic, I can never get a live vaccine. You know, unfortunately for me as an allergist, that's where I'm like, well, unfortunately for some folks, it can take 5 to 10 years for them to catch up as an individual practitioner to science. And science has shown it that that's not the case. And that's where you can use your own anecdotal experience, you know, by saying, you know, hey, I've been involved in giving children vaccines for X number of years. Now, if you're only an intern, or if you're like a second year, maybe don't do that. But you know, the more years you have under your belt, the more confidently you can say, I have been witness to thousands of children receiving vaccines. And the good news is that out of those thousands, the number of times that I have seen someone have anaphylaxis, I could actually count on 2 hands. And that's over 20 years of exposure and experience. What you don't want to do is, a common mistake that happens is to say, look, vaccines are 100% safe and effective, because again, they're a medication. So you don't want to make absolute statements that then might make them mistrust you. So step 1 would be acknowledge what they're saying, recognize their concerns, and set yourself up as being on the same trajectory in terms of what you want for this child and for this family. Have I had conversations where we kind of come to a compromise and we look at the vaccines and we figure, okay, what's the big risk? And I have had patients who have severe asthma they are on high dose inhaled steroids, and there's lots of kids in the family, and the parent doesn't vaccinate any of their children. And I'm like, you have to be kidding me. And after conversation, I got them to at least agree, let's vaccinate against the things that will cause meningitis and the things that will cause respiratory illnesses. And I actually did get two parents to eventually agree. And they were like, but I don't want my kid to get hepatitis A vaccine, hepatitis B vaccine. I don't want them to get tetanus. But the funny thing is, because tetanus is tied to pertussis, we were able to get that in. But yeah, that's where like my evil side came out. But they were very focused on no vaccines, and I at least got them to compromise. What are the vaccines that if your child got the actual disease, it could kill them? Because, I mean, this was a kid where he just went in for a regular bronchoscopy, and he ended up in the PICU for a couple of days because his airways are so twitchy. So I was able to get that mom to move forward, but really it's a conversation. Now, anybody who is in the military, there's also additional resources for military healthcare providers and military beneficiaries. So retirees, dependents, active duty, where if they have concerns about a vaccine, or if you have the vaccine resistant person, you can also reach out to your military allergist or the immunization healthcare branch under DHA. It used to be the Vaccine Healthcare Agency when I worked for them when they were under the Army, and now it's broadened. So that was a long way of explaining stuff, but hopefully everybody gets some nuggets out of it. Practice. Practice makes perfect. And in this case, find a friend who's going to be the anti-vaccine person, or read anti-vaccine websites to see what kind of things are proposed. And then you can logically figure out where the flaws are in that. That's something I do. I know it's like what trolls do, but I read anti-vaccine web pages. It's for fun. Other questions?
I'm gonna start doing that. That sounds fun.
It's very like, what? How do you even believe that? But then you realize, you'll see videos of people, they speak confidently. So one of the things that they talk about is like the vaccine, like the congressional funding for vaccine adverse events. And they're like, see, Congress has money because they know that this happens. And they don't understand the true history of where that came from. Or people talk about VAERS, Vaccine Adverse Event Reporting System. It's a passive reporting system. So if you want to, you can report that, hey, I got my flu shot, and then a month later I was pregnant, so I must have gotten pregnant because of the flu shot. You can report that if you want to. It is passively reported. Now, sometimes providers report, you can report as a healthcare provider, but also patients can report, parents can report, and they can report whatever they want, and it is in the data repository. So that's a flaw of the vaccine adverse event reporting system that a lot of providers don't understand. They think it's a place where clinicians report, and they don't recognize the fact that a lot of the reporting is coming from patients themselves or parents. Any other questions? No other questions. All right. So one of my tasks for today is to figure out how to get the Zoom video that I've been recording onto YouTube. So if anybody else is like, oh my God, you know what? Hey, it's Saturday night in social isolation. Let me learn. Feel free to have them look on YouTube. I didn't have an original handle because I just post lectures. This will be lecture number 3. But thank you guys. I hope you have a wonderful rest of your Friday. If you're in Hawaii, hopefully you get to get a little bit of vitamin D. If you're in other places, hopefully you are staying safe and you are checking up on your colleagues and your friends and your family to make sure they are also staying safe and that they are doing well. And with that, I am going to stop the recording and end the meeting.